Welcome to ASA Central Line, the official podcast series of the American Society of Anesthesiologists, edited by Dr. Adam Stryker.
Welcome to Central Line. I'm Dr. Adam Stryker, editor and host. I have Dr. Ahmed Shalabi with me today. Dr. Shalabi is a member of the ACE editorial board. With the 21B issue of ACE out now, we wanted to focus on one specific topic that's touched on in the issue: medical ethics, and specifically ethics in mass casualty situations. Dr. Shalabi, we are happy to have you with us today to discuss, so welcome to the show.
Thank you, Dr. Stryker, for having me.
To kick us off, why don't you go ahead and introduce yourself to our listeners? Tell us a little bit about your role and your experiences with ACE specifically.
My name is Ahmed Shalabi. I'm a liver transplant and a vascular anesthesiologist at Cedars-Sinai Medical Center in Los Angeles. I've been part of the ACE editorial board since January of 2022, so almost reaching a 3 years landmark there. I'm one of the editors of this editorial board, which has been a phenomenally enriching experience for me since I joined it. I get to work with a phenomenal group of anesthesiologists from all across the country. We work on authoring and editing this excellent group of questions that we issue biannually for the ACE question bank. It's been a fantastic experience for myself to know those colleagues, to learn from their experiences and their practices regionally, nationally, as well as internationally, to keep myself updated and sharp with my knowledge, working and learning new editing skill set has been a phenomenal experience for myself.
Wonderful. Well, medical ethics is such an enormous topic. I mean, there are so many different lenses we could view this topic through. From your perspective, though, what are some of the key ethical issues facing anesthesiologists today?
You're absolutely right, Dr. Stryker. It is an enormous topic, and there are several issues that face us as anesthesiologists on our day-to-day practice. To name a few of those that we run on a daily basis, for example, when we're taking care of patients perioperatively who have a do not resuscitate to do not intubate order, how do we work around that where we're planning to do anesthesia and intubate those patients? How do we discuss it with the patients or their families perioperatively? Given the fact that there are some issues that could readily happen perioperatively, it could be reversible, and how to respect the patient wishes at the same time and their autonomy. Another example for other subspecialties in anesthesia, like, for example, educating our pain colleagues, we're managing pain and combating the subconscious bias to certain groups while we're treating pain in our practice. Another example for myself, for example, when I'm taking care of liver transplant patients, how the allocation of liver transplant to certain groups and how that could be fair and sometimes questionable in certain groups that don't have access to medical care and less privileged communities. With the same token, like certain MELD exception points, when we use the MELD scoring system for allocation, that I have, for example, a patient that has a hepatopulmonary syndrome that would be allocated multiple MELD exception points as compared to someone who is as sick with end-stage liver disease but does not have that syndrome and ends up getting his organ allocated way after the patient that had the exception points. Also, like when we're dealing with patients who have some sort of an outside control in their decision-making. A good example of this were patients who are refused blood transfusion or for a variety of reasons. Some of them could be religious, some of them could be others. They could have some pressure from their families or some community members, and they're always afraid to be ostracized. So when we're consenting them, it's quite very important that I make sure that they have an informed consent, and I try to make sure that they don't have this outside pressure in making their informed decision.
Well, I know we want to talk about ethics and mass casualties specifically because it's currently highlighted in the current ACE issue. In general, as anesthesiologists deal with ethical issues, comment a little bit on what role does ethics play in helping us navigate some of the more complicated ethical issues? And B, are those services, committees and organizations or ethics consults readily available at most institutions?
So some of the most complicated medical issues, one of them is the mass casualty, which normally don't follow the normal traditional medical ethics. And we live in a world where we could face some of those instances due to certain attacks that could happen. The first thing that comes to my mind, for example, was the Boston Marathon attacks several years ago, or in even situations of mass casualties like, a perfect example was the COVID-19 pandemic, where the pandemic really overwhelmed the healthcare systems across the country and across the world. So traditionally, medical ethics teach a physician to put the patient's interest ahead of their own self-interest or preferences, or even ahead of any other person or any other patient's interest while they're taking care of that particular person. But in those kind of situations, sometimes we have to yield those traditional medical ethics in order for the utilitarian principle of providing the most good for the greatest number of patients. And institutions and facilities should have sort of preset protocols. And that's one of the lessons we should have learned from situations like this. And the most recent of them with the COVID-19 pandemic. We should be ready for the next disaster. Whether it happens or not, we should have pre-instated protocols, pre-instated guidelines, how to manage those things in an ethical fashion.
Okay, well, as we're talking about mass casualty events, can you give me a specific example within the framework of one of those situations you just highlighted, whether it's the Boston Marathon or COVID, of what an anesthesiologist might face in terms of an ethical dilemma in the mass casualty situation as opposed to their routine work situation?
Yes, absolutely. So in a medical triage situation, disaster is defined as any incidents where the local response resources are overwhelmed by the patient needs. And the goals of the medical management, as I mentioned, they change from those focusing on the patient individual needs to those for utilitarian good. So for example, if I have a situation where I have a terrorist attack next to a small community hospital, in this community hospital, they have a very limited number of operating rooms and a small number of beds. Anesthesiologists have the skill sets to really help in triaging those situations. These skill sets, for example, airway assessment, management of fluids and blood resuscitation, ICU expertise and knowledge, our knowledge of the operating rooms and what is available and what's, for example, if we know, are there any other surgeries underway and how I can allocate the remaining ORs for those trauma patients or the casualty coming in. Other resources, for example, like when we were doing the COVID-19 pandemic, how do I allocate ventilators and which patients are more likely to benefit and without compromising other patients. Another example, even after the initial triaging of patients coming in a mass casualty, there should be routinely periodic triaging of patients because some patients move from one category to the other, ones who initially presented in a less urgent manner and their medical status changes are becoming in a more urgent manner. A good example of this is what we call a lifeboat ethics. Well, a lifeboat ethics is if in a mass casualty situation, I have critically ill patients. At the same time, I have a critically ill terminal cancer patient in the ICU who's in a ventilator. And I have multiple trauma patients who are in a critical condition who might need a ventilator. And this comes a big ethical question. I have a very limited number of ventilators in the ICU. Which patients should use the ventilator and which should not? And in a mass casualty situation, all patients with lifeboat ethics, whether those on the lifeboat or those in the water, should be treated equally. And we might have to make a decision. That terminally ill patient, we might decide to resort to comfort care in situations where I might be saving the life of another patient who needs that kind of ventilatory support.
I see. Well, let's talk about a few specific terms that I know you want to define for our audience as it relates to ethics. We'll start off with one of the terms, if you could define it for us, but then also could you just explain to our audience why these concepts are important as it pertains to medical ethics? And let's start with the first term, deontology.
So deontology ethics is our day-to-day ethics as physicians and healthcare providers. What we call the duty-based ethics, it basically judges our actions based on what most people consider as morally correct, rather than the outcome or the consequences of those actions. So it takes into account the type of the action and our intention when we're determining it, and what is right and wrong in the initial decision and in our intention, not at the consequences of the act. And that's what could conflict in what I mentioned earlier about the mass casualty situations, where I have to make decisions based on the consequences and how to save as much number of people as possible. Deontology ethics tend to be patient-centered. As I mentioned, consequences are not used to justify the means. And the specific duties in deontology is what's right and what's wrong, what's evidently right and what we would consider as morally wrong. This is how we think in deontology ethics, like telling the truth, keeping promises, not letting someone die to save another person's life. A good example, if a terminally ill patient asks me, "Doctor, will I be okay after this surgery? And will I not have any major complication?" Deontology ethics would not suggest that I would lie to that patient to comfort them. And I have to be totally honest, as honesty is part of our obligation, and not lie, no matter what the consequences are.
Okay, now let's turn to autonomy then.
Autonomy is one of the 4 pillars of medical ethics, the 4 basic fundamentals of medical ethics. I'll talk about autonomy, and then I'll talk about the other 3 pillars. So autonomy is basically giving the patient the freedom to choose freely whenever and wherever they're able to. The other 3 main pillars of medical ethics are beneficence, meaning doing good to the patient; non-maleficence, do not do harm to the patient; and in my personal opinion, justice, which is the most important of them, ensuring fairness. In the context of medical ethics, is a principle that when I'm weighing if something is ethical or not, we have to also to keep into consideration whether it's compatible with the law, it's compatible with the patient's right, and it's fair and balanced.
And then finally, can you explain what consequentialism is, and how would that be salient to practitioners?
So consequentialism is a type of a utilitarian ethical concept. When we apply utilitarian ethics in the medical field, and it basically states that the morality of the action is based on the consequences, meaning that the end justifies the mean. And this is totally opposite of what I just mentioned about deontology ethics. So, for example, as in mass casualty situation, the resources may be redirected from patients with a low chance of survival in order to improve the chance of other patients who have a higher chance of survival. And this is what consequentialism is. It is not accepted in our standard day-to-day medical care of our normal course of patient care. However, it might be necessary in mass casualty to ensure the whole welfare of the public and save as many people as possible. Consequentialism might be a legitimate framework to make decision-making how resources may be allocated in such disaster situations, not to overwhelm our resources, the healthcare delivery, but it's not an ethical framework that I can use in my day-to-day medical practice.
So practically speaking, do practitioners need to know these terms? I'm sure everyone listening is familiar with these lines of thinking. They may not have known that there was a name to those lines or definition to how they were applying ethics, but how do most of our practitioners that are listening make sense of these different terms, these different philosophies as it pertains to their daily practice?
That's a very good question. And I think while the names themselves are not as important as the concept, and many, as you mentioned, do come as logical frameworks while we do practice in situations like this, sometimes there are areas where it could conflict and there are gray zones. And that's why knowledge of these situations or some examples of those could help us, giving from previous precedents, what are the potential conflicts that we could face in situations like this, and how to solve and resolve those issues.
Okay, now turning back to mass casualty specifically, how important is it for hospitals or other healthcare organizations to predetermine the criteria that will be used in mass casualty situations?
So regardless whether I'm applying consequentialism or any utilitarian frame of ethics versus a deontological ethical frame, it's very important that I apply the principle of justice, which is one of the main pillars of medical ethics. Because if I'm in a mass casualty situation, our decision-making might erode the trust of our patients in us. But if we have a predetermined framework and predetermined criteria, how am I going to allocate those resources that might guide me in my decision-making? That's paramount in applying the principle of justice to be informed. So all patients should be treated regardless what kind of framework I'm using in my decision-making. All patients should be treated based on their physical and mental condition only, rather than their social worth. No other characteristics should warrant any special consideration in a disaster situation. That includes age, gender, or any other race or any other characteristics. However, there are only few exceptions to this rule where I can prioritize certain social criteria. And a perfect example for this was the prioritizing the COVID vaccines for physicians and other essential healthcare workers during the pandemic. So this was a perfect example of a mass casualty or a pandemic where I'm in a situation I need to vaccine the healthcare workers before anyone else so they don't get sick and they could care for the rest of the public. So there are very, very few exceptions where I can violate this rule about applying justice and equally providing the care based only on the physical medical condition. And one of them is vaccination during pandemic.
Many healthcare organizations have plans in place for mass casualty situations, or they've run mass casualty drills. Do you feel that the ethics questions that we've been discussing so far are not addressed enough in those plans or in those drills? Then when these situations arrive, each one, which has their different considerations, it's left up to the practitioner at the time. But is there not enough prep work as it pertains to ethics? And does that end up causing the practitioners on the ground level when the mass casualty event happens to have to sift through these ethical questions in a very urgent fashion?
Well, the short answer to your question, I think there is room to do more prep, though I don't think it should be enough, meaning that I think COVID-19 showed us that we were not ready enough, and not only in our nation, but also across the world for situations like this. And I hope we learned the lesson from that. We should have the experience from the last few years, how to address, God forbid, if they happen, similar future epidemics or pandemics. And the second part of the question is, in situations, for example, like mass casualties, there are some well-known triaging protocols which help the physicians guide how to prioritize those situations. And I think integrating those in our teaching with our trainees, or even in our continual medical education, for us to expand our knowledge of those. Because sometimes, despite being really well intended, in situations like this, where a lot at stake, we could still make a decision to spend and use a lot of our resources taking care of casualties that have very little chance of survival, which could compromise the likelihood of survival of patients who had initially a higher chance of survival, should have been addressed earlier. And a perfect example of this, there are some triaging color coding protocols that have been used in mass trauma situations or mass casualty situations. For example, using like simple color code triaging systems, red, yellow, green, blue and black. And basically, the first two, the red is basically who patients who are extremely critical, but may survive with simple life-saving maneuvers. For example, like alleviating airway obstruction, or treating a hemorrhage with transfusion or resuscitation, or treating a cardiorespiratory failure by some hemodynamic and respiratory support. And this is where an anesthesiologist, his skill set could really come and play. And those have to be allocated to immediate care. Patients who are triaged yellow are those at next priority, or basically patients who have penetrating wounds, but they are in a more stable condition. So they might not receive the immediate care if the resources are overwhelmed, but they could go into the next priority right after we address the first category. The other two categories, which is like the green and the blue, the green are basically the patients, what we call the walking wounded, where patients are quite stable, they have wounds, but it can wait. And those can be addressed as soon as the resources are available, as soon as the other more critical patients are addressed. The blue, which we call the dying, or the black who are already dead, those could be allocated to comfort care only of still alive. So the green and the blue category, if I'm able to identify them early, I could more wisely allocate my limited resources in situations of mass casualties. The main difference between this and warfare triaging strategies is warfare, I'm trying to treat the less wounded soldiers to get them more readily back to combat. In medical triaging mass casualty situation, I'm trying to treat those who have as soon as possible critically ill, who have a higher chance of survival, and allocating the resources to them more than who have very limited chance of survival, or those who have minor injuries that could wait for later care.
Now, I understand you chose this topic, right?
Yes,
for
correct.
the ACE issue? Okay. Can you talk to our listeners a little bit about, in general, the process of selecting topics to highlight in ACE, and then also why this one specifically?
So I'm going to answer the second part of your question first. So I remember in December of 2020, when the first vaccines for the COVID-19 were approved by the FDA, myself and my wife were working in the same hospital then, and we got vaccinated, being first-line specialties, first-line responders in the hospital in the first week as soon as the FDA got approved. At the same time, going back home, my son couldn't be vaccinated, and our friends and family who couldn't reach the vaccine. And that really was, at that point, I really wanted to understand the reasoning. It was quite obvious that we're first-line responders, we're at a higher risk, and we want to take care of the population. But going back, when I chose this topic and looking back at it in retrospect, and looking how we saw our colleagues getting sicker while they're taking care of the patients and getting COVID-19, some of them had to stay out of work until they recovered. Some of them actually getting critically ill, and we took care of them in ICU. And I think this is what we wouldn't normally do in our day-to-day practice, prioritizing ourselves or prioritizing specialties like us as anesthesiologists or high-risk specialties in medicine to receive the vaccine. And I thought that this might be a point where we to dig more into literature and see where the origin behind these kind of ethical questions or where answers to this come from. And I chose to bring this up to the audience of the ACE question bank to test their knowledge and to highlight on the importance of knowing those few concepts. But in general, when we use the topics for the ACE question banks, we try to discuss updated evidence-based medicine in anesthesia, cutting-edge technologies that change our anesthesia practice, newer societal guidelines. We try to keep our audience updated with the new medications that are approved or in the process of being approved by the FDA that we're using in our day-to-day practice. We try to choose our topics from all subspecialties to be comprehensive to the audience practicing different subspecialties in anesthesia. And at the same time, our group is very diverse in their subspecialty skill set. We also try to look into topics that we tend to overlook in our day-to-day training with our residents and fellows. And medical ethics is one of the things I think we should be emphasizing in our training and in our didactics, as well as in our products, to help enrich our audience, enrich their knowledge about many factors that we can be used in situations like this.
Well, Dr. Shalabi, thank you for joining us, giving us a peek behind the scenes of ACE, but more importantly, talking about some of the intricacies of a very important topic, medical ethics, and a lot of facets that we oftentimes don't think about until we're placed in a situation like that. So thank you so much for joining us for a very interesting conversation.
You're very welcome, Dr. Stryker, and thank you for having me.
Absolutely. And for our listeners who are interested in the 21B issue of ACE, you can find it at asahq.org/ACE. And thanks for tuning in to this episode of Central Line. And don't forget to please tune again next time. Take care.
Shake off the stress of residency with ASA's Early Career Membership Program. See how much you can gain and save with this program at asahq.org/ECMP. Subscribe to Central Line today, wherever you get your podcasts, or visit asahq.org/podcasts for more.